And I have all the pleasure to introduce this afternoon's speaker, Professor Ahmed ElKeraie, Professor of Nephrology from Alexandria University. I first came to know Ahmed since over 22 years on a trip to the ISN Congress at Buenos Aires. He was such a very inspiring young man, full of energy. And as I see, Ahmed now is not only my friend, but really he has become such an outstanding nephrologist and an outstanding professor. I always admire his attitude and how he functions, and I'm sure that he's going to give us a very enlightening talk about something new that is really needed in the field of nephrology. تفضل يا أحمد.
ستيب داون وخلاص.
لا ازاي خد الميكروفون.
السلام عليكم ورحمه الله. بسم الله والحمد لله والصلاه والسلام على رسول الله صلى الله عليه وسلم واشهد ان لا اله الا الله وحده لا شريك له واشهد ان محمدا عبد الله ورسوله. I really do admire Professor Tariq for very warm and nice introduction. واعتز جدا بكلمتين اللي حضرتك قلتهم وبصداقه حضرتك كاخ اكبر ومثال يحتذى. Thanks for the conference and the organizing committee and AstraZeneca for this chance. And we'll be discussing today hyperkalemia, which is a very well-known issue and very bothering condition. And maybe most of us have lost patients or almost seen patient lost due to hyperkalemia. But what we're trying to do today is to dig down to find out how we can improve the management to our hyperkalemic patient and who are the potential hyperkalemic patient who are at danger. First, let's start by such a few teasing questions, and we'll answer them at the end, hopefully. So, which of the following sentence best expresses your opinion about hyperkalemia? How do you think? Is hyperkalemia a temporary condition that prevents you from giving a patient who deserves a RAS inhibitor in a way or another? Or is it a problem that should be kept under constant? That when you do that, you contribute to the progression or decreasing the progression of chronic kidney diseases, for example, or other diseases. So how do you look at hyperkalemia? And how do you think, out of your daily practice, is the percentage of hyperkalemic patient? Is it around 10% or is more than 25% going by the different trajectories? Just keep the answers in your mind. At what potassium level do you start your management? What do you think the level that you should act upon? And this is a bit of a debatable issue. Is it 5, or do we accept that our patients are more tolerant to hyperkalemias, so we are more reluctant to act upon a potassium which is less than 6? Or would you go on for 5.5 or 6.5? And when do you start to act? Not when it is severe, but when do you start to act? And how would you act? Would you start by sodium bicarb, glucose insulin, nebulization by beta-adrenergic receptor, go for dialysis immediate, adding other agents? How would you act? So please just keep in your mind the answers for these questions. And then when you go down with the potassium level, what's your chronic management for a patient who is susceptible or who had a previous hyperkalemic episode? Would you only restrict high potassium diet? Would you give traditional potassium binders? Would you add diuretic? Or would you down titrate the hyperkalemic drugs with the RAS inhibitors? So let's move and try to find out who are the patients whom are at high risk of hyperkalemia. We all know that advanced CKD equals more potassium in the blood and less potassium in the urine. Patients with diabetes are type 4 RTA, which is usually associated with hyperkalemia. And those with congestive heart failure are maintained on a multitude of drugs, the Magnificent Four. 3 of them are hyperkalemic agents, beta blocker, RAS inhibitors, or the RAS plus the sacubitril and the MRA. The 3 of them causes hyperkalemia. And patients with resistant hypertension, we usually tend to give a spironolactone for those patients, assuming that there is an element of hyperaldosteronism, and this might cause hyperkalemia in those patients. And this is the percentage of hyperkalemia with the stages of CKD, and you can see that it can mount up to 50% of your patients in stage 4 CKD and maybe 30% in stage 3. And in all other trajectories of patient diabetes, myocardial infarction, heart failure, and people who are using RAS inhibitor, there is significant level of hyperkalemia in all those patients. And the worst thing is, once it occurs, it recurs. And it recurs more aggressively and more closely. And this is very important issue. Once you had a patient with hyperkalemia, he will suffer from hyperkalemia later on, and you can just follow this dark red column where at the first episode they were like 27%. Within 7.7 months, it's 43%. Then with a closer period, 5.9%, it's 57%. Then with a closer interval, 4.8%, it's 64%. And as if you're speaking about the stages of decline of the GFR. So hyperkalemia mirrors in a way or another the GFR in those patients, and it recurs and recurs more closely. And moderate and severe hyperkalemia are common among patients with renin-angiotensin-aldosterone system inhibition, whether using ACE and ARBs or an MRA or a combination of these. There is definitely increasing level of hyperkalemia, and much more in the late stages of CKD. And these patients, usually when they are CKD and heart failure, there is an increased prevalence of hyperkalemia that might mount up to half of your patients with stage 3 and 4. And we all confess that we are much more confronted with patients who are cardiorenal patients. They are very much increasing, not only in prevalence and incidence, but also in severity. And we do use these drugs to try to save their hearts. And definitely when you have a diabetes with CKD, the chances of hyperkalemia is higher than when you have a CKD without diabetes. And that's why the RAS inhibition, which was recommended by the KDIGO in both diabetic and non-diabetic CKD patient, as long as they are not dialysis dependent, you should use it in diabetic patient whom are A2 or between brackets more than 300 milligram per day proteinuria, and in diabetics when they as well as previously known as macroalbuminuria, even without hypertension. In non-diabetic, they have to have a hypertension to give an RAS blocker with a proteinuria. And the risk of hyperkalemia definitely would increase in those patients, as we previously mentioned, and over 5 years of follow-up, like third of your patients would have hyperkalemia when they are on a RAS inhibitor. Okay. And definitely, again, it increases when the GFR decreases. And as a pattern of practice to management of hyperkalemia, definitely glucose insulin is still the first agent to be used. IV calcium comes next, and inhaled beta-2 agonist, then the oral sodium polystyrene sulfate and intravenous bicarb, dialysis, and a little bit of intravenous diuretic. So we have to be aware of this issue of what to do with the hyperkalemia. Let's look a fresh look at hyperkalemia and look for an agent that is expected to come, and we've been waiting for a while for this agent to be here, which is SZC, or the sodium zirconium silicate, which is just a crystalline form of an inorganic compound that is not a polymer, and it is insoluble, non-absorbable, and it has a high affinity for potassium, and it do exchanges sodium for hydrogen and potassium. And the very important issue about these few characteristics is it is super selective to potassium, because the size of the mesh of this molecule is like 30 angstrom, which fits very nicely into the, or 3 I mean, which fits very nicely into the size of the potassium molecule, and comes the ammonium afterward. Whereas the magnesium and calcium are much smaller, so they do not fit. And this is very important point we have to mention later on. This is the difference, the main difference between the readily available potassium exchange resin, the sodium polystyrene sulfate, versus the sodium zirconium cryosilicate, silicate, I'm sorry. And you can see that the affinity for the potassium in Lokelma is very high, whereas the calcium and magnesium chelation is almost zero, very negligible. And the reverse is with the SPS, cation binding. It chelates calcium much more than potassium, and chelates magnesium a little bit more than potassium. Lokelma have been studied in 3 major trials. The first one is the harmonize, and the extension is the extension of this harmonized trial, and the dialyze is the one for people on dialysis. The harmonized study design is initially to, it's an open label phase. You do a 48-hour correction by using SCZ in 10 grams TID for 2 days to correct the acute hyperkalemia. And then people were double-blinded to whether to receive placebo or the Lokelma at 5 gram once daily, or 10 gram once daily, or 15 gram once daily. And then they extended this harmonize into the extension, which is 10 gram once daily for 11 months after the initial 28 days in the harmonized study. And the primary endpoint was to go with the potassium and compare it between the placebo and the SCZ groups, whereas in the extension is to go below 5.1, to go with the potassium equals to or below 5.1 millimole per liter, or milliequivalent per liter. And the secondary key endpoint was to look for the change from the baseline potassium according to the intervals, and to the proportion of the patient who achieves normokalemia after 1 and 2 days, and to the time for potassium normalization. Whereas the secondary endpoint in the extension study was to look for patients who achieve a potassium of less than 5.5, not 5.1, slightly higher than 5.1. And these were the key inclusion criteria, which is almost would be, as you expect, the same with the exclusion criteria for other patients who are not who are on dialysis or not compliant to the treatment, or who are having arrhythmia or another active treatment for potassium. And this for the correction for acute patient profile. And the message here is it acts rapidly, which is not the case with the available potassium exchange resin. So it acts within 2.2 hours. It decreases potassium within 4 hours, from the previous hyperkalemic level to almost 5 or 5.1 within the very first 4 hours of treatment, and the median or the mean of that was 2.2 hours. And then potassium goes down by 0.2, 0.4, 0.5, 0.7, up to 1.1 millimole per liter at intervals of 1, 2, 4, and 24 and 48 hours respectively. The other thing is that it consistently reduces serum potassium regardless of the comorbidity. It goes down with the potassium regardless whether the patient is diabetic or CKD or CKD history or taking RAS inhibitor or whatever. And the maintenance in the extension, as you can see, it maintained the patient in the normokalemic versus the placebo, which was above the level, above the potassium level, as you can see here. And this in the extension trial, all of the patients for 11 months were in the normokalemic range. And when you stop it, within 1 day it started to rise. And at the exit of the study time, like after 7 days, it comes back to the previous level of the hyperkalemia. And this is the endpoint, primary and secondary, around 80% achieving the primary and almost 90% achieving the secondary endpoint throughout the study. And this allows us to give RAS blockers, whether initiate or escalate the dose or add another RAS blocker like, for example, Spectone plus ARBs, or example. And this is the concept K with the KDIGO, where you have to optimize potassium by whatever mean, but not decrease or stop RAS inhibitor for those vulnerable patients who are in need for it, specifically if they are a heart failure patient. Lastly, the dialysis study is a study in the long interdialytic interval. Simply, we all know that patient dies on the long days of dialysis, and this is the U curve related to the all-cause mortality and the potassium cardiovascular mortality related to the potassium. When you have a low potassium or a high potassium, your patient dies. And there is an increased incidence, 2.4 on the long interdialytic day, of having a very high potassium level, up to 61% of patients. And dialysis does not correct the potassium for good. It corrects immediately, but 1 hour of the dialysis rebound will happen, and 6 hours of the dialysis patients are hyperkalemic again. And so you need to give a supplement that decreases potassium specifically on the long interdialytic day. And this was the rationale for dialysis study, and it randomized like 200 patients on the placebo or the SCZ arm, and the primary endpoint was achieving normokalemia on the long interdialytic day, which was very much appreciated with the SCZ in relative to the placebo. And I would say just, if you give me just 1 minute, this is the, can I have 1 minute? Okay. This is what have been adopted by the NICE and the UK Renal Association, is to use the potassium in the COVID-19 pandemic to decrease the necessity of emergency dialysis for those patients with end-stage renal disease and patients with acute renal failure, because you can postpone dialysis if the patient is not at the threatened level of hyperkalemia. Safety profile is okay, and in most of the cases it's not too much different from the placebo. And the major adverse side effect was congestive heart failure only in 1 case, which is nothing out of 45 cases, and it was even in the 5 gram, not the 10 gram, which need to be explained. Sodium content is not too much. I mean, it should not cause heart failure or deterioration of blood pressure. And the regular adverse side effects are almost the same. Maybe upper respiratory tract infection was more prevalent, again in the 5 gram once daily dose. Edema, only 1 patient. And as you can see, there was no big difference between the placebo and the other doses. And this is the maintenance dosing. You start in the correction phase by 3 sachets of the 10 gram for 24 to 48 hours. Then you maintain by 1 sachet per day. It could be 5 gram, or it could be 10 gram, or it could be even 5 gram every other day according to the level of potassium. Whereas in the patient who are on dialysis, you would give on the non-dialytic day 5 gram, and you can increase this up to 15 gram once daily, and these have been included in the summary of product characteristics based on the dialysis study. I would thank you here, and I'd like to have refreshment answers for the teasing questions at the beginning of the presentation. Thank you.
Thank you very much, Professor Ahmed. A very clear and comprehensive message, and you have addressed well our patients. Our patients are dying from their heart, not from their kidneys. And unfortunately, what we are all doing once hyperkalemia sets in with RAS blockade and MRAs and so forth, we just stop these drugs that are needed for our patients. Now you are opening a new scope of therapy, which seems to be offering a good control of potassium and avoiding all those serious side effects that we see with the old forms of therapies, particularly that you mentioned, and I'm going to say it again because this is a very important message. Once it occurs, it recurs. This is a fact. I guess all of us are aware of this. Once it occurs, it recurs. We can take 1 or 2 questions from the floor if you like, or answer the questions that he himself asked. ما تحط الأسئلة تاني لو ينفع؟
ممكن أول سلايدز كده بسرعة. Just كده what's your consideration of hyperkalemia? I mean, is it ممكن معلش تفتح لي is it a temporary condition just that prevents you from using or optimizing RAS inhibitor? Or is it a problem? I mean, that you have to live with and try to constantly manage, as it might affect the prognosis of your organ, whether it's kidney or the heart. So you choose number 2, as if once it occurs, it recurs. Hyperkalemia would persist with your patient, and you need to manage it in a constant way. Right. Next, please. Allow me to. Okay. ده من حضراتكم بقى، يعني ده variable practice. يعني how do you think the number of patients اللي حضرتك بتشوفهم with a hyperkalemic episodes how much؟ طبعا دول اللي يفرقوا، اللي شغال mainly transplantation غير اللي شغال mainly CKD غير اللي شغال mainly dialysis غير اللي شغال كله. لكن in what average do you see your patients with hyperkalemia؟ هو الحقيقة السؤال اللي بعد ده المفروض يجي قبل ده، اللي هو how do you consider a level of hyperkalemia؟ يعني what do you think is hyperkalemia is أكتر من 5.5 ولا أكتر من 5؟ definitely مش هنقول أكتر من 6 و6.5، ده definite معروف إنه hyperkalemia، لكن ممكن نقول severe hyperkalemia. لكن what do you consider it؟ أكتر من 5.5 ولا أكتر من 5؟ 5.5. هو احنا كلنا بنكونسيدر أكتر من 5.5 in our practice، لكن هو الجايد لاينز بتقول أكتر من 5. ويمكن هم كونسرفتيف في الحته دي شويه، علشان الاكتر من 5 از برون انه يبقى اكتر من 5.5 واكتر من 6 بسرعه. فوانس ان احنا ولو احنا بقى راجعنا نفسنا تو بي اونست، يعني العيان اللي البوتاسيوم بتاعه 5.1 حضرتك هتوقف له السبكتون او هتقلله للنص. وممكن كمان ايدك تاكلك على الفالزرتان او اللوزرتان او الايربيزرتان وتقول له بص كده مش هضمن اسيبك شهرين عليه. تو بي اونست. يعني اكتر من 5 لو هو في حاله وما بياخدش حاجه هتقول له موز وجوافه. لكن لو اكتر من 5 وبياخد فعلا راس انهبيتور وبيتا بلوكر ونيورال هتوقف له. فهي دي الايشو يعني. لكن البراكتس الحقيقه how much they are not scarce. يعني انا myself I would go for more than 20%. يعني من العيانين فعلا بيكون الليفل بتاعهم 5.5. What's your first option for severe hyperkalemia? الثلاثة ولا نمرة ثلاثة؟ نمرة ثلاثة جلوكوز انسولين يعني. Yes, that's what we do. جلوكوز انسولين. بس الفكرة الكبيرة قوي في الجلوكوز انسولين it's not a treatment for hyperkalemia. It's masking for hyperkalemia. هو مجرد بيدخل البوتاسيوم جوه السيل وبعد شوية هيطلع لك تاني. ف you did not get rid of the potassium. انت بس عملت له شيفت عشان تحمي الهارت. او تحمي المصل او whatever يعني. it's a big issue. This is not a real treatment يعني. again وزي ما شفنا كمان even الدياليسيس هو بيقلل momentarily ورابيدلي طبعا، لكن الريكارنس هيحصل والريباوند هيحصل بعد شويه. you need to have a way. سواء بقى كانت اللي هي لما ندخل على السؤال اللي بعده دايت ريستريكشن. والدايت ريستريكشن الحقيقه في ايشو وده بازلنج ايشو، ده عايز بقى جلسه بيه كده نفصص فيها الارتكل اللي من كام سنه بتاع الديسكاليمياز ان سيكي دي بيشنت، لانه البوتاسيوم is not evil all the way and we have to understand this. البوتاسيوم مش شيطان يعني. البوتاسيوم ده احنا بنحبه قوي للهايبرتنشن يعني. وبننصح البيشنتس انهم ياخدوا اللي هم ما وصلوش للليفل اوف هايبركاليميا انهم ياخدوا هاي فروت اند فيجيتابل دايت علشان البوتاسيوم، لو صح ان احنا نقول كده بالبلدي يعني.
البوتاسيوم وعشان المغنيسيوم وعشان الفيتامين كي.
وعشان الفيتامين كي صحيح. صحيح.
Look, we are running. We already run of time. I'd love to hear you more and more. I just have to end this session. And thank you so much. And thank AstraZeneca. And thank the audience. شكرا.